this cardiovascular stuff. Okay, I can see that there are 7. So I'm going to move on to the next question, or not, depending on how long we take to filter through. Well, I'm going to move on to the more useful question, which is this one, which is I'd like you guys to sort of select the 2 topics that you'd like the most help with. Yeah, and it'd be really useful to sort of get at least most of your guys' responses so that we can have some kind of consensus on what to spend more time with, because there's a huge amount in this lecture in order to try and get it, and it's going to be a rush to get everything done in time. All right, so is that most of us? I'm not sure how many people are actually in chat right now. If that's most of us, I'm just going to keep going. All right, so let's see what everyone wants to do. All right, so most of us want to do guidance models followed by shock and heart failure. All right, that sounds good to me. So, going to get on to the presentation. And starting with your preference for hypertension, for guidance models, okay. All right, cool. So all the slides are visible and stuff? All right, so Guyton's model and all of Guyton's stuff. So there are 2 things in your syllabus that Guyton is responsible for, and one of those are his curves for cardiac output, and the second thing is pressure natriuresis, which is covered in long-term control of blood pressure. So what we're going to be focusing on right now is what Guyton did in terms of his model for cardiac output, which is how much blood the heart pumps. So moving on to the first slide, which is important here. What factors determine cardiac output? So Guyton hypothesized that 2 factors affect cardiac output. The first is the heart itself, and so the heart's ability to pump blood. And then the second factor is the tendency of blood to return from the heart to the peripheral vasculature. So if you remember from first year, Frank and Starling had their cardiac function curve, and that described the relationship between right atrial pressure, i.e. how much fluid is in the heart, and how much blood the heart pumps. So one half of the puzzle was already solved. So knowing that we've already described the heart itself, Guyton wanted to focus on the tendency of blood to return back to the heart from the peripheral vasculature. So this is what Guyton's experiment is all about. And so Guyton's idea is that the pressure of the entire circulation, which is related to how much blood is in it, affects how much blood comes back to the heart. And he called this mean circulatory filling pressure. So that's a big term. We're not going to focus on it too much. We are going to focus on it, but after I've explained to you all of this sort of gobbledygook. So we have Guyton's experimental setup here. So to run you through it, I'm not sure if you guys can see my mouse. I can switch it to a pointer if you would like. Laser pointer here. So he had his heart and he hooked it up to this experimental setup. So I'm going to start here at the pump. So this pump is moving blood around this system, and this pump is simulating venous return to the heart. So this is simulating blood flowing back to the heart. And this is a flow meter. So this records the flow. This records how much blood is moving through this experimental setup. And this feeds into the heart here. And then here we have a manometer, which is a way to measure how much pressure's in the right atrium. And then we have this Starling resistor here. And essentially all we need to really know about a Starling resistor is that using this, Guyton could vary how much resistance there is here, how much the right atrial pressure is. In this setup, the Starling resistor is like your stand-in for right atrial pressure. And so he's able to change right atrial pressure by moving this resistor up and down. And then this extra detail here is a blood reservoir. And using this, Guyton is able to control how much fluid he puts into the system. So we have our pump for venous return. We have our Starling resistor here simulating right atrial pressure. And then we have our blood reservoir here controlling how much blood goes into the system. So those are the three main things here. So now that we sort of hopefully understand that, what Guyton did is he kept the rate of pumping constant throughout the experiment. So he fixed this pump at a fixed rate. And then for a given volume of fluid in the system, he increases right atrial pressure until flow stops. And he plots this on a graph. And that's what this graph is here. As you see, along the x-axis, we have right atrial pressure. And then on the y-axis, we have venous return. So as you can see, we start off at negative atrial pressures, and Guyton raises the height of this resistor. So he increases resistance until the venous return stops, until the system stops flowing. And this point here, this pressure here, is what he calls the mean circulatory filling pressure, because that's the amount of pressure that it takes to stop blood returning to the heart. So if that's the case, that is the amount of pressure the system is flowing with, if that makes any sense. So we stop the flow with a certain amount of pressure, and because that's the value of pressure we need to stop the flow, that's the pressure the system is flowing with. And that's what he calls mean circulatory filling pressure. So, and then what all these additional curves are is he repeated the same experiment for different volumes of fluid. So, he measures the point at which a system stops flowing for a certain volume of fluid. He then opens his reservoir, this pinch clamp here, and he pumps more blood into the system, so we've got more fluid. And what we find is that the mean circulatory filling pressure increases, but this gradient remains the same here, which makes sense because when we're adding more fluid, we're not necessarily increasing the sort of the gradient throughout the system. We're just affecting how much pressure we need to stop the flow. And so he repeats this for ever-increasing volumes of fluid, producing these very famous venous return graphs, which have confused med students for a long time now. So we have these curves, but what do these curves actually mean for cardiac output? So now there's a lot of text on these slides, but that's because these slides are going to get sent round to you after you guys fill out feedback. So it'll mean the explanation's there. So what you guys can do is focus on the graph on the right here. So Guyton himself wrote that the venous return curve doesn't mean much by itself. So that's this blue line here, the venous return curve. But when you put it together with the other half of the puzzle we were talking about earlier, this Frank-Starling curve, you put them on the same graph, it actually becomes a really useful way of modeling how the heart and the peripheral vasculature together affect cardiac output. So you're probably asking, why on earth can we put these on the same graph anyway? Well, the logic's kind of like this. Venous return and cardiac output are like two sides of the same coin, because if you imagine our circulation, the blood that comes out of the heart goes back into the heart. So that's why we can plot these on the same graph. And so how do we read cardiac output from these curves? Well, it's kind of like simultaneous equations, if you remember that from way back when. We've got one curve describing one half of the puzzle, how blood returns back to the heart, and we've got another curve describing how blood leaves the heart. So the point at which these curves intersect, which is known as the steady state operating point, this is our point that determines cardiac output. So we've got this point here, we move to the left, and we can see that we get some value for cardiac output. Now, I put a little note here in the bottom left corner, because what you're going to often see in a lot of graphs online as well is this term mean systemic filling pressure. So as far as we're concerned, that's essentially the same thing as mean circulatory filling pressure. The only slight difference is that the mean circulatory filling pressure is the pressure in both the systemic and the pulmonary circulations, whereas mean systemic filling pressure is the pressure just in the systemic circulation, so not counting the pulmonary system. But when Guyton measured these values experimentally, they worked out to be roughly the same anyway. So you don't really need to think of them as different things, really. So we have these curves. Why are these curves even useful? So it's because we can use this to try and explain the effects of sort of modulating our cardiovascular system by, say, injecting fluids or increasing cardiac contractility or decreasing cardiac contractility. We can model all of that using these curves. So the first thing we're going to do is we're going to model the effect of increasing or decreasing circulating volume, the amount of fluid that's in the blood system. So let's say we start here at this point here. So when we increase volume, as we remember from our experiment, when Guyton added more volume in, the mean circulatory filling pressure increased. So here's our original venous curve here. Let's go to the mean circulatory filling pressure. So we've added volume in. This increases the mean circulatory pressure along the x-axis. So it shifts this entire line to the right. So, and if we look back at where this new line crosses the cardiac function curve, it crosses it a lot higher up. So we can see that increasing the circulating volume has increased cardiac output. And this also intuitively makes sense, because if we have more blood in the circulation, the heart's going to have to pump more to keep the fluid moving around. So it also kind of intuitively makes sense. And now let's say we took volume out of the system. So let's say if you're losing blood, so this venous return curve shifts to the left. And so as we can see, we would get a lower cardiac output. So the second thing we're going to model is the effect of increasing and decreasing cardiac contractility. And this one's a little bit more straightforward. So let's say your heart pumps normally here, represented by this middle curve here. If your cardiac contractility increases, the gradient of your cardiac function curve would increase because your heart's pumping harder. And so if we read where the lines cross, you'll get more cardiac output. Similarly, if you're, say, in heart failure, your heart's not pumping as much, your contractility decreases. And so where the lines intersect is here, which is lower, so your cardiac output has decreased. So the third thing we're going to model is the effect of increasing or decreasing systemic vascular resistance. And this one's a little bit trickier. So when you increase vascular resistance, the total amount of blood in the circulation remains the same, at least in this model. So your mean circulatory filling pressure remains unchanged. So this point here along the x-axis doesn't move when you get a change in vascular resistance. But you do get an increase in venous resistance, which reduces how much blood flows back to the heart. So let's say this curve here is your original venous curve. So when we get an increase in vascular resistance, so vasoconstriction, this point remains the same, but the gradient is going to decrease. And this is because there's a less steep venous return curve because there's less venous pressure. You can think of it that way, allowing blood back to the heart. So your steady state operating point moves down and you get reduced cardiac output. So I think I stumbled on my words a little bit, so that probably wasn't the best explanation, but essentially what happens is that blood flow back to the heart becomes more difficult, and that can be represented by a decrease in gradient here. So you get this sort of rotation of your venous curve down. So those are the main sort of basic situations that we can model using the curves. Is that all kind of clear? Is someone able to unmute, because I can't quite see chat, unfortunately.
Yeah, I think that's good.
Okay, so if that's good, what we can do now, list for shock, what we can do is, I'll come back to using these guidance curves to model shock and things, because I'll come back to it later, because it's not going to make much sense until we've actually covered what shock is. So I'm going to go back to shock here. And then we'll come back to modeling shock later, using the Guyton models. So, what is shock? Shock is a pathophysiological state of inadequate oxygenation of cells and tissues. And so you could either not be getting enough oxygen delivered to your cells and tissues. Your cells and tissues could be consuming more oxygen. They could be inefficiently utilizing oxygen, or you could have a combination of all three processes occurring. So again, a lot of words in this slide, but all this slide is really showing you is the classification of shock. So we have four big types of shock: distributive shock, cardiogenic shock, hypovolemic shock, and obstructive shock. And from memory from your syllabus, the big important ones are septic shock here, cardiogenic shock, and hypovolemic shock. I'm not sure if anaphylactic shock was included or if you guys cover anaphylaxis in a separate part, but we can go over that if you want to. So, because shock is very much a clinical syndrome, we need to take a more clinical approach. So this is going to be from a little bit more of a clinical perspective. So how do we know that someone's in shock? The most common features that suggest shock are marked hypotension, so your patient is very, very low blood pressure, tachycardic, so their heart's beating quickly, tachypneic, they're breathing really quickly, abnormal mental status, so they could have reduced consciousness, for example, cold, clammy extremities, that's a sign of peripheral vasoconstriction and decreased blood flow to the peripheries, so that's quite important, and metabolic acidosis. And the important thing to note is that the initial approach to shock is the same. So no matter which kinds of shock, no matter what kind of shock it is, you're going to do the same thing for your patient because your priority is to stabilize them. And this is where the sort of more clinical approach comes to it. Your patient's in shock, the first thing you're going to do is get help. Sorry, you're not going to call the heart failure team. That is a typo. If you suspect heart failure, you call the heart failure team, but you probably call ICU instead, or try and get the patient to critical care. And then once you've gotten help and gotten the patient on that pathway, you're going to start your A to E approach. You're going to try and stabilize their airway. You're going to give them oxygen. And importantly, in case of shock, you need to obtain IV access, because what you're going to do is you're going to immediately give them IV fluids, followed by vasopressor therapy, depending on if it's needed, to maintain tissue perfusion. And of course, you want to take blood glucose and ketones to rule out hypoglycemia or diabetic ketoacidosis, which are two other conditions which potentially could give you some of the same symptoms. So you want to eliminate those two conditions as a potential cause for your patient as opposed to shock. So your patient presents at ED, they are pale, they have a blood pressure of 78/30, and they're tachycardic. You find that they have a temperature of 39 degrees Celsius. You notice that the skin on their left calf is erythematous, so it's red. So my two questions here, which you don't have to answer, but I'd just like you to think about is, what do you think could be going on here? And what would you do? So the main important things here, well, is that firstly they're in shock, but also that they have a fever. 39 degrees Celsius is a fairly high temperature. And also the skin on the left calf is red. So we're thinking maybe there's an infection going on and there's some kind of cellulitis here. So what do we do in this situation? So we suspect sepsis, and so the patient could be undergoing septic shock. So you're going to get help, you're going to do your ADE assessment, but then where this sort of differs is if you suspect sepsis, you're also going to do something called the sepsis 6. So, and the important things here are, these 6 steps are all important, but you are going to give IV antibiotics because that's going to kill the bacteria, and you're also going to give fluids. And we say give a fluid challenge, and that's because we're able to determine their fluid balance because we would have gotten their urine output as well. So basically give fluids, antibiotics and fluids. And you would do these other things such as taking blood cultures to see what kind of bacteria are responsible, and you give oxygen as well. So our second scenario here, the patient presents at ED, they're pale, they have a blood pressure of 60/40. On examination, they have bilateral pitching edema and bibasal lung crackles. You note that they have a history of heart disease. So what do you think this is, and what do you do? So again, we're just going to have a little think about this. So this could be cardiogenic shock. So in this case, yes, we would call the heart failure team because we suspect heart failure as well. And then we do our A to E approach again. In the case of heart failure, we'd give IV loop diuretics. We consider a right heart catheter. And we'd also give inotropes such as dobutamine and vasopressors such as noradrenaline. And if the patient is arrhythmic, we may want to treat their arrhythmias, so we will give them something like amiodarone if that's the precipitating cause of cardiogenic shock. And for the sake of time, we're not going to do a third clinical scenario, but for hypovolemic shock, which is where your patient's losing a lot of fluid, what you want to do is you need to get IV access. That's important because you want to replace the fluids, and you're going to aggressively give them IV fluids. If there's hemorrhage, so if they're losing fluid in their circulation because they're bleeding, you'd want to do a group and save in preparation for blood transfusion. And then after that, you treat the underlying cause of hypovolemic shock. So, for example, if they're bleeding, you'd want to perform some kind of surgical intervention to stop the bleeding. So, and this brings us back to Guyton, because I believe another dot point on the syllabus is an interpretation of what happens in shock using the Guyton curves. So this slide here, we remember our 3 basic changes that we can do. We can change volume, we can change cardiac contractility, we can change vascular resistance. But as we know, reality is a little bit more complicated, and this can sort of affect how we model the effects of interventions. So I don't necessarily think you need to know the following for your exams, but it can help you sort of explain what actually happens when we administer medication in shock, as well as what happens in shock. Now, what happens in shock itself can be a little bit complicated, so I'm going to start with modeling the effects of medication. So, modeling the effects of the pure vasopressor, so something that constricts your peripheral vasculature. So, let us start at this normal blue line here. So step one, you administer your vasopressor, you're going to get constriction of large veins, and this decreases venous return. So we get this decrease in gradient here, which we remember from the other slide. However, what also happens is you get constriction of venules and small veins. And what this does is this affects the ratio of something called stressed and unstressed volumes. You don't need to know that at all, but it's simply, I'm just mentioning it here as a bit of background, because if you do decide to do a bit of extra reading, you may come across these terms. But the ultimate result of this is that you actually increase systemic filling pressure, so mean circulatory filling pressure. So what actually happens when the small venules contract is that your curve will shift to the right. So this blue line shifts to where this green line is here. So that happens. So that's what happens on the venous side. But what happens on the heart side when we constrict our peripheral vasculature? Well, we get increased afterload because the heart has to work harder to do the same job. So our cardiac function curve will actually decrease as well. So we've got our green line and our orange line. Where do they cross? Here. So this is our cardiac output here. So the net effect of giving someone a vasopressor means that you actually get a decrease in cardiac output, but you've increased right atrial pressure and other filling pressures. So in other words, when you give a vasopressor, it's a little bit complicated. You're not necessarily increasing cardiac output. So let's say you give IV fluids. That's essentially what colloid means in this situation. So when you increase volume, your venous curve shifts to the right, as we remember. So let's say we start here, shifts to the right. This is our curve, new curve. But what can happen is that when you administer IV fluids, you get hemodilution. So, because when you think about it, when we give someone IV fluids, it's not like we're giving them more red blood cells as well. So this sort of dilutes the blood. So that actually decreases resistance. So as we remember, when we decrease resistance to flow, we increase our gradient. So to recap, we started here, we've moved to here, and now because of hemodilution, we get decreased resistance. So the gradient increases, so this curve here rotates to the green line. So this is our venous return curve. And what can also happen, although I'm not sure it's necessarily as important, is due to this hemodilution, you also get decreased afterload to the pulmonary arteries, so you can get an increase in your cardiac function curve, resulting in an even greater increase in cardiac output. But to be honest, I think just mentioning the fact that there is hemodilution is enough, because the end result's the same, cardiac output increases, which in itself is fairly intuitive. So on to modeling shock. All these diagrams come from this paper here, which is also in the slides. So I've only done this for one system, hypovolemic shock, but if you want to see how it works for all the other kinds of shock, I definitely recommend giving this paper a read, because they modeled it fairly well. So what happens in hypovolemic shock? We're losing blood. So we get a loss of volume. So we're starting here at normal. We lose blood, so we move down to this green curve here. So what happens now? Well, what happens when we lose fluid is that our body compensates. And these effects are mediated by catecholamines. So these catecholamines will cause constriction of the small vessels, and it'll also result in interstitial fluid shifting into the blood vessels. So you'll get some sort of compensation to increase the circulatory filling pressure again. So this green line moves up to this yellow line here. Also, what catecholamines do, as we remember, is they increase cardiac inotropy. So your heart beats harder, in other words. And so our cardiac output curve increases, from normal to red. So as we can see, your body has some compensatory mechanisms to try and increase cardiac output again. But this only sort of sufficiently works and is able to compensate for a loss of less than 15% of your total circulating volume. So we have a person in hypovolemic shock, and now we want to model what we're going to do, all the interventions we're going to do to try and help them. So let's consider what happens when we give them an infusion. It can be modeled by the same shift from green to yellow that we talked about previously, because we're just increasing circulatory pressure. Now, we can also observe changes in cardiac inotropy, because now that we've fixed your volume to an extent, your heart mechanisms can work properly again. And so your heart, which has more contractility because of residual effects from this mechanism, will also be increased. So we can use the same lines to model the effect of giving IV fluids. However, later on, so this is when you've really given them fluids and their system's starting to return back to normal, you can actually get decreased venous resistance, which may be due to vasodilation, vasodilation or hemodilution, And so that can actually increase the gradient here, which results in a higher cardiac output than normal. So that's what all these curves mean, which is covered by this paper here. So are we sort of feeling a little bit okay? It's understandably definitely complicated, but this is sort of a way you can make sense of it using these curves. So if there are no questions or any uncertainties, I'm going to move on very quickly once again. Oh, sorry, completely lost my pointer. There we are. Okay, so it'd be easier for me to... Oh, what is going on? All right. Sorry. So now we're going to go back to the beginning to cover this in order, because I think hypertension we also wanted to cover, but to sort of understand hypertension, we're going to need to understand blood pressure control. And this will also lead us to the second point about Guyton, which is pressure natriuresis, because as we remember, I mentioned earlier, Guyton not only worked out our cardiac output curves, but he also did pressure natriuresis. So let's start with speaking a little bit broadly. What is blood pressure? Well, it's the force of our blood on our arterial walls. So I'm not sure if you like maths, but you don't need it, it doesn't need to be mathsy, but I think it definitely helps. A key equation we'll be using to structure our understanding of blood pressure control is this one here, where blood pressure is equal to mean arterial pressure, where blood pressure, which is sometimes called mean arterial pressure, is equal to cardiac output multiplied by systemic vascular resistance. And so all mechanisms that affect blood pressure affect cardiac output or systemic vascular resistance in some way. Also, something you may see out there when you do your reading is you might see total peripheral resistance. So total peripheral resistance and systemic vascular resistance are the same thing, and they're used interchangeably. So, where does that blood pressure equation that I mentioned previously come from? It comes from what's known as Ohm's law of fluid flow. So if we remember I equals V over R from high school physics, similar concept, blood flow or flow through any system is equal to the pressure difference across that system over the resistance of the system. So we rearrange this equation. The pressure difference across the system is equal to the flow times the resistance. So let's apply this to our circulatory system. Mean arterial pressure minus central venous pressure, that's the difference across the circulatory system, is equal to the cardiac output times the systemic vascular resistance. Here, cardiac output is our stand-in for flow, and systemic vascular resistance is our stand-in for resistance. Now, when we measure central venous pressure experimentally, it's usually near zero or at zero. So we often simplify this above expression to mean arterial pressure or blood pressure is equal to cardiac output times systemic vascular resistance. So moving on to short-term control of blood pressure, and we're going to have to start picking up the pace a bit. So baroreceptors found in the carotid sinuses and the aortic arch respond to stretching of the arterial walls. Your conduction system has two types of fibers, large myelinated A fibers, and these are responsible for the second-to-second maintenance of blood pressure. So you're going to get your blood pressure changes. So let's say your blood pressure increases a little bit, it's going to be your large A fibers responding quickly to this. And the second part, small A fibers and unmyelinated C fibers, which provide tonic basal control. Signals from your carotid sinus and aortic arches are transmitted to the nucleus tractus solitarius in the brainstem via the glossopharyngeal and vagus nerves, respectively. The important part here is that when you stimulate the NTS, it increases parasympathetic signaling to the heart, and it decreases sympathetic signaling to the peripheral vasculature. So this results in decreased cardiac output and decreased systemic vascular resistance, both of which contribute to decreasing your blood pressure. This next slide here is a diagram that I drew because I like working with diagrams and I think it's a lot easier to remember. So if you're able to remember like a diagram like this, it contains like all the relevant information for your short-term control of blood pressure. As you can see, we have our receptors conveyed to the nerves to the medulla, nucleus tractus solitarius. And there are some other steps in the brainstem, other nuclei here. But the important thing is that this ultimately results in decreased heart rate, decreased stroke volume, decreased systemic vascular resistance, all of which decreases arterial pressure. And I think these are from the right-hand side of your syllabus, not the left. So these are the extension points. One of which is your baroreceptors actually can reset. So normally their sensitivity, peak sensitivity to change is around where your normal mean arterial pressure is. So small changes in your blood pressure from this normal point greatly alter the rate at which your receptors fire. And so this allows you to respond quickly to changes in blood pressure. But let's say you're doing exercise and your blood pressure increases. So if that happens for an extended period of time, your baroreceptors actually reset, which allows your blood pressure to go higher, and allows you to sustain blood pressure, have the same kind of regulation at higher blood pressure values. And then with chemoreceptors, the important points are that they're in the carotid bodies, they respond to hypoxemia, low oxygen, and hypercapnia, a lot of carbon dioxide, and they increase heart rate and stroke volume and decrease systemic vascular resistance. So, clinical relevance, you can get autonomic dysfunction in the elderly due to injury to nerves from stuff like diabetes and Parkinson's disease. And as a result, in your elderly, they can be susceptible to falls. So they can get orthostatic hypertension. And then similarly, carotid sinus hypersensitivity, you apply pressure to the carotid sinus, and it can result in syncope, transient loss of consciousness, because your baroreceptors are stimulated and your blood pressure drops. So now onto long-term control of blood pressure. So primary mechanism is pressure natriuresis. And so what does pressure natriuresis mean? It means that increases in your blood pressure result in increases in sodium excretion by your kidneys. How do we even find this relationship between blood pressure and sodium excretion? Coleman and Guyton in 1969 found that they could produce experimental hypertension in dogs by administering isotonic saline and also surgically reducing renal mass to 1/3 normal. I presume they did this to increase the effect of their experiment. So this hypertension they found was reversed when the dogs were switched back to water instead of saline. And then they found that when they switched from water back to saline after that, the dogs got hypertension again. Also, it's been shown in isolated kidneys and dogs that increased blood pressure results in increased urinary sodium excretion. And you can find that out by measuring how much comes out, as well as measuring the blood pressure and correlating the two. So, we know from what I just said that higher blood pressure means increased excretion of sodium. But why are blood pressure and sodium, salt, even related? So that's the reason why I introduced this equation: blood pressure is equal to cardiac output times systemic vascular resistance. The reason why salt matters is because salt intake affects cardiac output. Your salt causes increased extracellular fluid volume, which leads to increased blood volume. And this is due to hydrostatic pressure from the extracellular fluid at the capillaries. So you can think of it as there's more extracellular fluid volume, and that pushes sort of against the blood in the circulation. So you kind of get a fluid shift into the circulation from the extracellular fluid. And so, as we remember from Guyton's curves, we have more blood in the system. This increases mean circulatory filling pressure. So it increases cardiac output. And this is from Guyton and Hall. It sums up what I've just said. We have increased extracellular fluid volume, leads to increased blood volume, increases mean circulatory filling pressure, which results in increased cardiac output, which from our equation increases arterial pressure. And by pressure natriuresis, increased blood pressure means increased salt and, by extension, urine output. And this acts to decrease the amount of fluid in our body. So it's a negative feedback loop, so it regulates itself. And so now I'm going to go on and talk about the acute and chronic pressure natriuresis curves. So the kidney will excrete salt until salt excretion matches salt intake. Sorry, I'm getting a bit of a sore throat. And so this point where salt excretion matches salt intake determines what your blood pressure is going to be. And I've drawn a red arrow to it. And what we find is that when we increase salt intake, the kidney compensates by increasing how much salt it excretes at the same blood pressure. This is represented by a shift in the pressure natriuresis curve. So as you can see, here's our moderate intake. And for high salt intake, we actually get your kidneys excreting more salt. So the equilibrium point is actually here. Now this is the acute pressure natriuresis curve. This line here is our chronic pressure natriuresis curve, and that happens when we join up all our different lines. So now that we sort of have established our chronic pressure natriuresis curve, we can use that to understand a couple things. So if I direct your attention here to this line here, what we can see is that in a person with healthy kidneys, changes in salt don't really result in a big change in arterial pressure, as we can see from this line here. But what happens if our kidneys aren't excreting salt very well? Well, then changes in salt actually produce bigger changes in blood pressure. So these people are called salt sensitive because their blood pressure responds well to reduction in salt intake. Alternatively, some people who are hypertensive do not respond to salt because their kidneys excrete salt. And so these people are salt insensitive. So mechanisms of pressure natriuresis. So let's look at the endocrine stuff in here. And all your endocrine stuff is going to act through this equation. We're going to cover the RAS system, ADH, adrenaline, and cortisol. So there's a big diagram here, which I got from Wikipedia. But the important things that you really need to take away is that decreased blood flow to the kidney results in increased renin, which results in increased angiotensin II. That's a big thing to remember. And this effect is mediated by the juxtaglomerular apparatus. And essentially, your juxtaglomerular cells contain renin, which is released in response to a couple things: decreased renal perfusion pressure, beta-1 adrenergic receptor signaling, and purinergic signaling from the macular denser cells. So renin cleaves angiotensinogen to angiotensin 1, becomes angiotensin 2, and it exerts all these effects downstream, which I'm going to let you read. But I'm going to draw your attention to aldosterone and vasoconstriction and ADH secretion. And here's some clinical relevance, which you can read in your own time. Onto ADH, two main sites of action, the kidney and the vasculature. In the kidney, it increases apical expression of aquaporin 2 in collecting duct cells, and this allows your kidneys to reabsorb water. And then in the vasculature, it causes vasoconstriction. I'll let the small note here of clinical significance: diabetes insipidus and SIADH. And there's a lot of resources online covering these two conditions. Moving on to adrenaline. Adrenaline binds all the adrenergic receptors non-selectively. So this has two main effects. It causes vasoconstriction via alpha-1 and increases cardiac output by binding to beta-1. And then another point of clinical relevance, is pheochromocytoma, which are adrenal gland tumors that secrete catecholamines. And these can cause malignant hypertension, which needs to be treated because it affects survival drastically. Now, cortisol, the mechanism is not so clear, so I'm not too sure how much of this is going to be in the syllabus, but essentially cortisol increases hypertension, but we don't quite know why. Essentially is what this slide is saying, and there's a whole bunch of experimental stuff here for your reading interest, and if you wanted to talk about this in an essay maybe. So moving on to hypertension now. So the key concept I need you guys to understand in hypertension is risk. Hypertension, as according to various organizations such as NICE, which we tend to follow in the UK, defines hypertension as a blood pressure measured in clinic of greater than or equal to 140/90, or an ambulatory or home blood pressure greater than or equal to 135/85. But this value may seem a little bit arbitrary. Why? Because blood pressure is continuous. So why have we chosen 140 and not 138 or 136? Why have we chosen 140? Why is this the cutoff point for hypertension? So this decision is ultimately a clinical one. The key question we need to ask is, at what point is blood pressure worth treating? So according to European guidelines, hypertension is defined as the level of blood pressure at which the benefits of treatment unequivocally outweigh the risk of treatment as documented by clinical trials. So as we know from systematic reviews and longitudinal epidemiological studies, all-cause mortality, mortality from cardiovascular disease, and risk of end organ damage increase with increasing blood pressure. These bottom 2 points are a little bit of extension. They might count towards a perceptive one or something. But because our decision is clinical and it's based on evidence, public bodies can actually disagree as to the interpretation of evidence and whether or not they decide to include certain pieces of evidence in their decision-making for their guidelines. So this can lead to disagreements in where the cutoff for hypertension should be. And this is why there's conflicting guidelines from the latest American and European guidelines. I think America classifies 130 systolic as hypertension. So here's some of the evidence behind why we treat hypertension and the risk. This is from the Framingham Heart cohort. And essentially, if you are hypertensive, you're at greater risk from coronary heart disease. The takeaway from this slide is that the higher your blood pressure, the greater your risk of death due to coronary heart disease. The main takeaway from this slide is that its treatment is definitely beneficial. The green line is hypertensives who are treated and have well-controlled blood pressure. The red line here is those who are untreated. And as we can see in these Kaplan-Meier curves, the people who are treated do much better in terms of survival compared to those who are not treated. Classification. As you can see, we have optimal, normal, high normal, grade 1, grade 2, grade 3. We're going to be focusing on grades 1 and 2 because that's where a lot of our decision making happens. And these are a list of risk factors, the big one, smoking, and you've got all these other risk factors here. So, principles of management. I think this is where sort of the real money is. So, the key concept, as I iterated before, is that we need to weigh up the benefits to the patient versus the risks of treatment. Another general principle in management is that we progress from the least invasive to most invasive procedures. So this would be lifestyle modifications, followed by medical intervention, followed by surgical intervention, if there is a surgical intervention that helps. So this is another big slide with a lot of details, but the reason why I've included it is because I'm going to explain to you the principles of why the guidelines are the way they are. So if we remember, it's all about risk. So people who have stage 2 hypertension, we say they're definitely at risk, definitely recommend starting antihypertensive medication. For adults who are younger than 80 with stage 1 hypertension and other risk factors, we discuss starting antihypertensive drug treatment and we would recommend it. But for adults who are older than 80 with a blood pressure of greater than 150, we start needing to weigh up whether or not the benefits to their lifespan when they're already 80 is going to be more than the risk of causing them a fall and other sequelae from falls like hip fractures, which are pre-terminal events in the elderly. So you start needing to balance risk there. Adults who are less than 40 with hypertension, that's fairly rare, or not necessarily fairly rare, but you start thinking, is there something else going on there? Is there a secondary cause of hypertension going on? Similarly, if you see any signs or symptoms that suggest a secondary cause of hypertension, consider specialist investigations. So these are your antihypertensive drugs, angiotensin receptor blockers, ACE inhibitors, calcium channel blockers, and diuretics. So these next two slides are big tables, which you can go back and refer to with the drugs, the mechanism of action, contraindications, and adverse effects. But I'm going to point you towards a couple key things. Here, for ACE inhibitors, contraindication is patients with previous history of angioedema. Calcium channel blockers, watch out for constipation and peripheral edema. In thiazide diuretics, you can induce hyperkalemia, and same thing for loop diuretics. And the important thing to remember is that in potassium-sparing diuretics, the adverse effect is the opposite. It's hyperkalemia as opposed to hypokalemia. So that's a big one to remember. And this is another big flowchart from NICE, but the reason why I put it here is so that you can sort of fit in where all these medications fit in terms of how you would actually treat a patient. And so this can be sort of read in your own time. But essentially, the principle is that depending on the age and ethnic background of the patient, you start with a different set of medications because studies/evidence suggests that some medications might work better for some patient groups than others. And this is just a paper that goes into the guidelines and discusses it at length. So if you're interested or want more sort of experimental evidence and perspective points, this would be where I'd go to. And this is just a syllabus document about essential hypertension. The main thing is that these cases are idiopathic. And these are just the pressure natriuresis curves. Now onto heart failure, which I'm going to have to really zip through. We might run about, because we started quite late, we might run maybe 5 minutes overtime if you guys want to stay for like 5 Socrative questions. So heart failure, essentially the heart is not able to pump as well as it normally does. and this is caused by any structural or functional cardiac disorder that impairs the ability of the ventricle to fill or eject blood. Why does heart failure happen? Well, we think an initial event causes myocardial damage, which results in increased myocardial wall stress. And the event could be any of these three things. This leads to the activation of multiple endocrine systems, such as the renin-angiotensin system, the sympathetic nervous system, and the release of cytokines. And whilst these systems are beneficial in the initial stages of failure because they act to try and increase cardiac output, long-term, these mechanisms here are maladaptive because they cause cardiac hypertrophy and remodeling, and they can cause fibrosis in the renal parenchyma, affecting your kidney function, which both can perpetuate the progression of heart failure, so it becomes a vicious cycle. And this is just a diagram summarizing the neuroendocrine mechanisms and whether or not they're beneficial or pathophysiological. And this is just a slide on etiology and the different causes of heart failure, which you can read. So we don't necessarily have time to think about this, but this is just, again, the structure of clinical medicine: history, examination, investigations, diagnosis, management. Just giving you don't need to know this, but this is just important to give you a rough idea of what your syllabus dot points are even referring to in terms of symptoms and signs, which are on your syllabus. So these are really the key symptoms and the key signs that you want to find, or if you find them, you'd start thinking heart failure. Bibasal crackles just means crackles in the base of both of your lungs. That's all that bibasal crackles means. So, again, although not in depth in your syllabus, I believe your syllabus mentions the therapies of heart failure, but I'm going to go through more broadly your approach to heart failure because that's how you sort of fit in all your different therapies into an overall structure. So investigations is just stuff that you do to help reach a diagnosis of heart failure. And what you must do in all patients with suspected heart failure is an echocardiogram, because you want to detect any kind of structural abnormalities. In terms of your treatment, you've got three different kinds of heart failure: acute heart failure, chronic heart failure with preserved ejection fraction, and chronic heart failure with reduced ejection fraction. And here's where I'm going to do a little bit of a mini rant on your syllabus dot points. So your syllabus says left and right ventricular failure. But the thing is, while you can classify heart failure as left-sided or right-sided or biventricular, this distinction is not necessarily that useful clinically and may not change how we manage the patient. So what actually happens in reality is that clinicians first tend to ask, is the heart failure acute? Because we want to know, is the patient stable and not going to die? If heart failure is acute, our priority is to stabilize the patient. Then if the heart failure is chronic, we further categorize it by how well the heart pumps. If it's heart failure with reduced pumping ability, that's heart failure with reduced ejection fraction. If it's heart failure with relatively preserved pumping ability, so your heart still pumps fairly well, that's heart failure with preserved ejection fraction. And this is a management plan of what you do in acute heart failure. And these are all the quote unquote therapies that you would administer in this case. And the main point with this big flow chart, you don't need to know all this at all, but it's just to help you make sense of where individual therapies fit in to the overall management of acute heart failure. Moving on to chronic heart failure, main therapies here are ACE inhibitors and beta blockers, plus a mineralocorticoid receptor antagonist if just ACE inhibitors and beta blockers don't work. And again, there's a lot of stuff here in this slide, but it's just to help you picture where each therapy fits in overall management. So you see, for heart failure with preserved ejection fraction, you can't really do very much. But for heart failure with reduced ejection fraction, we can do some things. We can offer these medications. And if these don't work, we can then consider offering these other medications here. And so that is our lecture. And I'm going to quickly pull up some Socrative things.